I've had MG for 6 years. It took me 4 years and 9 neurologists to get diagnosed. I figured it out after 18 months and 3 neurologists, and it took battling with the rest of them to make it official. When I finally saw neurologist number 10, she said, A, you are not crazy. B, you have MG. C, you know a lot more about MG than the neurologists that you've been seeing. This set of sentences should never happen. All right, so what's myasthenic crisis? A lot of people confuse crisis with flare and exacerbation. Super, super important. You have to get the terminology straight, okay? A crisis is specific to respiratory muscles. I got into a huge Facebook discussion with a person who said, I just survived my first crisis. I'm so glad I didn't have any breathing problems. No, you did not have a crisis, okay? It's specific to respiratory muscles. Those muscles get so weak, no air goes in and out, the person can't breathe, okay? When it gets so bad to the point where you need help breathing, you wind up either on BiPAP or intubated and on a vent, okay? It's very, very important to keep these straight. When patients show up at the hospital and say, oh, I've been in crisis before, and they say, oh, but I've never been on BiPAP and I didn't have any respiratory problems, the communication with that doctor then falls to zero. Okay, so very, very important. Flare and exacerbation means everything in the body. Trouble swallowing, the double vision gets worse, I start falling, that kind of stuff. But crisis is specific to respiratory muscles. Okay. Again, crisis, okay? MG crisis triggers, okay? For me, high doses of steroids are a huge trigger, okay? Antibiotics, certain ones. These are certain things that can happen. Illness. I had my appendix out a couple years ago. Threw me right into a wicked flare. Okay, choking leads to aspiration pneumonia, where the fluid go down into the lungs, stress from trauma or surgery. Okay, all these things can trigger a crisis. Okay, it can happen very slowly or very quickly. Somebody who's had a slow progression in the past can have a very quick and rapid progression a later time. Okay, so it's very important for patients to be able to tell when a crisis is warming up so they can get help before they wind up unconscious, unresponsive, and not breathing, okay? Some people say, well, I was admitted with a crisis, but I didn't wind up intubated and on a vent, okay? Sometimes the docs will admit the patient to the hospital with an admission diagnosis of crisis in order to get treatment started, okay? They might be on BiPAP, or they'll start plasmapheresis or whatever, but that is the admitting diagnosis, and it means specifically that the patient's respiratory muscles were failing. Okay, and aggressive treatment is needed to prevent a full-on myasthenic crisis. You want to keep that person off the vent. Okay, one of the biggest concerns that I see in the MG community is I feel short of breath, but I don't know if it's anxiety or if I'm working on a crisis. How do I tell? Okay, and I love Anxiety Girl, able to jump to the worst conclusion in a single bound. Okay. It's better to figure out, you know what, I'm going to treat this as if it's MG. If it's anxiety, great. But we need to rule out and make sure that this isn't an MG crisis on the way. So there are some simple assessments patients can do at home to check and make sure. Okay, which one is this? The neurologists need to be teaching the patients this, and the patients need to know these. Okay? Signs of poor breathing function. These are things that you do not commonly see with anxiety. Okay, one is the official term is orthopnea. Okay, you can't lay in bed flat, and that's where I am right now. I actually got a bed that lifts the head of the bed up so I can breathe and be in my bed all at the same time. It's wonderful. Okay, if you find that you cannot breathe laying flat, you're gasping for air, okay, probably your MG is acting up. That is not consistent with anxiety. Rapid shallow breathing. Okay, people who are anxious are taking those deep breaths or hyperventilating. People with MG, it's very shallow. There's just a little bit of air moving, okay? Having to pause in the middle of a sentence to take a breath. This is called interrupted speech or staccato speech, Okay, this is a very, very important sign. And this is something that I see when I'm heading towards crisis. And I have to pause every few words to take a breath, and I start talking like that. Okay, that is a very, very important sign. If you start seeing that, it's time to get checked out. Okay, and that weak cough. Okay, you can't clear saliva, you can't clear any mucus from the throat. Okay, that's very dangerous. It sets the stage for pneumonia. Okay, if you have to work to breathe, there are what called accessory muscles, and they're up here around your collarbone. And if you start struggling to breathe, you start using those accessory muscles, and you see these collarbones and the shoulders start to lift. Okay, accessory muscle use is not seen with anxiety. So if you stand in front of the mirror and you can see your collarbone starting to really work, okay, that's the time you need to be checked out because you might be working on a crisis. Okay, sweating when the room is too warm. If you're getting a workout trying to breathe, time to get that checked out. Waking up frequently during the night gasping for air. That is never seen with anxiety, especially if you've not had a bad dream. Okay, very, very important. That means that the body hasn't been breathing enough, especially during that REM sleep, and the body's waking up because it's just not getting enough air. Okay, restless, agitated, drowsy, or confused. That means one of two things. There's not enough oxygen going to the brain, or there's not enough CO2 being blown off. Okay, those two things from not breathing sufficiently causes all sorts of wonderful mental status changes. Okay, if the person gets really bad, you'll see that the chest wall starts to move in rather than expanding during breathing. That's called paradoxical breathing, not a good sign. And when the person starts feeling too tired to keep breathing, usually what happens is if it's not treated, the person goes into respiratory arrest and stops breathing. Okay, and that's obviously something that we never want to see happen. Okay, single breath count test. This is something that all patients with MG, especially those with respiratory involvement, should be taught. The patient counts out loud after taking as deep a breath as possible. Okay, you count out as quickly as you can while saying each syllable. So 1, 2, 3, 4, 5, and see how high you can get. Okay, when I'm doing fantastic, I can hit 50. I have not hit 50 in a while, but that's my personal best. Okay, this morning I was at 30, so I took a little bit more prednisone. Okay, if you cannot get to 20, you need to be in the ER. Okay, very, very important. A lot of physicians do not know this trick, including ER physicians, but it's a really, really good way for patients to tell, where am I? Okay, so if I'm feeling short of breath because I'm anxious, I can blow 50. If I'm feeling short of breath because my respiratory muscles are getting weak, I'm blowing 25. Okay, that can tell me right off the bat which it is. Okay, so when to seek help? I love Homer. What's the number for 911? Okay, this needs to be on speed dial. It's very, very important for patients to work with their neurologists to say, okay, when do I call 911? When do you want me to call 911? What's the changes? When do you want me to call you? And when should I head to the emergency room? Every patient should have a plan in mind about what to do. What signs should lead me to get this checked out? Okay, nobody wants to go into the hospital with lights and sirens if they don't have to. Okay, when should I call the neurologist? Okay, MG is a rare disease. Your average paramedic, should you have to call 911, will go, wow, is that MS? What is that? Okay, so if you have to call 911, there should be information printed out about MG to provide to them, to say what to do, okay? You want to have a packet on your refrigerator or handy, has your med list, allergies, your med history, okay? Maybe not that you had your tonsils out when you were 6, but you have a history of asthma and MG. That they want to know, okay? Physician phone numbers, that includes your neurologist, if you have a pulmonologist, okay? All the docs that are important to take care of, okay? And your ICE numbers in case of emergency, okay? The ICE numbers, those are numbers that you put in your phone. So in case of emergency, okay, they would call my husband, okay, or they would call my mom, okay. And if you have an Apple iPhone, there's a little section where you can put in emergency numbers, and they're handy stored right there for you, okay. EMTs should do a careful respiratory assessment. They'll probably figure that one out, okay. But they will not understand that the pulse ox is not an accurate indicator of respiratory function in the MG patient. We are different. We snowflakes, we tend to have a great pulse ox no matter how bad our respiratory status is. Okay, it won't drop until right before we stop breathing. Okay, so it's really important to educate those EMTs to say O2 sat will be fine, but you can still have a patient in respiratory failure. Okay. So that is really important to educate them. For the most part, EMTs are very educable, okay? If you tell them what to look for and what to do, they will generally go with it and listen to you, okay? EMTs should, if the pulse ox is less than 90, straight up give oxygen. But if it's 99%, don't give it. Too much oxygen is actually a bad thing, okay? If the person can't breathe, obviously they should breathe for them, okay? Some EMS teams carry BiPAP, and it's great. Put the mask on the face, and it will shove air in through the mask to breathe for you. It is really cool. It's like going on I-75, and I got my head stuck out the window, and I'm going about 90 miles an hour, okay? If you cannot breathe, though, it is the most fantastic feeling in the world. It is great. I'm like, air, okay? If you put the mask on and force air in that way, a lot of times you can avoid having to shove the tube down the patient's throat, okay, and intubate, okay? BiPAP is great. Those patients who are getting tired and they can't breathe, okay, we're going to help them breathe, okay? BiPAP is preferred because people with weak respiratory muscles cannot exhale against that high CPAP pressure, okay? CPAP is good for sleep apnea, but once you go into the wonderful world of MG, you need the cool BiPAP, okay? Intubation, if the person's unconscious, if they can't swallow, or if they stop breathing, we have no choice. The tube is going down, okay? But we'd like to avoid that if possible, okay? If you are going into MG crisis, urgent care is not the place for you, okay? You should be transported to the nearest emergency facility, okay? We don't want to be driving 2.5 hours across town to the hospital where your neurologist is, okay? Have the neurologist call the nearest hospital where you're going to be sent, okay? Be sure to bring, okay, brief medical history, okay? Like I said, hit the highlights. It doesn't matter that you had your tonsils out when you were 4, okay? But you have an MG history and you're allergic to whatever meds, that you have to bring. Current med list, including IVIG and treatments. The neuro number, the pulmonology number, all your important physician phone numbers, okay? In case of emergency phone numbers and information about myasthenic crisis care. There is a document posted on the MGFA website, this emergent management of myasthenic crisis. You should print that out and bring that. There's information for EMS and information for the ER physician. Okay. Once you get to the hospital, Dr. Guptill is going to explain that a little bit more, but we're going to do careful monitoring, tests, ABGs, and very important, patients may be dismissed as being anxious. Most causes of respiratory failure will see that pulse ox drop right away. And when the doctor comes in, sees the person struggling to breathe, the pulse ox is 98, they're like, it's anxiety. No, it's not. It's unique to neuromuscular respiratory failure, okay? And it's a big challenge sometimes to educate those docs about that. So it becomes a battle, okay? Pulmonary function testing, I believe you're going to go through. So these are things that you should expect to see done, okay? We're going to find out how strong those respiratory muscles are or how weak they are, okay? It's really, really important that the doc looks at the patient, okay? I've seen some really horrible physician care. I've been the recipient of some really horrible physician care, including one doc who said it was all anxiety without ever having seen me. He managed to figure it out over the phone. He had some amazing superpowers to be able to do that. And then he ordered a sedative for me, which is the last thing you want to give somebody with neuromuscular respiratory failure, okay? So very, very important. The doctor has to come up and see the patient, and they want to look at the trend of numbers over time. If my single breath count is normally 35 and I'm down to 30, that's one thing. If my normal breath count is at 50 and I'm down to 30, that is a huge drop, okay? So I want to look at the trend of numbers, see that patient, okay? Talk to that patient, listen to those lungs, okay? Careful observation will never, ever take the place of looking at numbers and test results, okay? Signs for ICU admission. If the person can't count to 15, that person needs a bed in the ICU. Vital capacity, if you can't blow a liter, you need to be in the ICU, okay? You don't want to wait for low pulse ox or abnormal ABGs because then it's going to be too late, okay? One of the biggest things is the inability to lift the head from the pillow. Very, very important, okay? Can use BiPAP, okay? And Dr. Guptill is going to explain that a little bit more, as well as Mestinon. Okay, want to stop medications, want to treat any infection that's going on. Okay, some other treatments. You could do IVIG, plasmapheresis, and steroids. High doses may initially cause worsening. I received 3 grams of Solumedrol over 3 days, did a big pulse thing, put me straight into crisis on BiPAP in the ICU. And then the doc said, oh, it was anxiety. Told me I was a waste of the hospital bed, told me to go home and to go see psych. The psychiatrist I saw, I went to go see to clear my name, said, oh, you are totally not psych, and she wrote me my first prescription for Mestinon. Okay, this is not the way an MG diagnosis should go down. Okay, advocating for yourself. Okay, I cannot stress this enough. MG is so rare. And I saw a lot of physicians who think that they know a lot about MG when they really did not. Okay, so it's very, very important that you learn the terminology. Okay, learn what accessory muscles are. Learn what those pulmonary function tests are. Learn the difference between a flare and a crisis. Okay, learn about the different meds and how they work. That way you can understand the doctors and have a good dialogue with them. You need to effectively communicate with them, okay? And you need to be able to make informed decisions. So you know what? High-dose steroids can cause initial worsening. Probably not the best idea for me. Can we try something else? Okay? Okay, be prepared to educate those healthcare providers. Okay? One of the unique things about being in crisis is you can't talk effectively to do that. Okay, so you need to have a second. You need to have somebody who's going to be there, who understands the disease, and can pin that doctor down and go, hey, peak flow is not indicated for checking respiratory function. Why didn't you do these other ones that are? Okay, how come you're not bringing that Mestinon in? It's due now. The person needs it. Okay, it can really advocate. Okay, print information about MG. Print that information that's on the MGFA website. It's got the MGFA website logo at the top. It's got credibility. The advocate needs to shove that in the doctor's face. I gave that to my doctor in the ER when I was there last, and it said, order these tests, and she promptly ordered something completely different that had nothing to do with MG. Okay, I wasn't able to talk enough to really argue with her. Okay, so now your second is going to get that information, shove it under the doctor's noses, and make sure the doctors follow it. Okay, bring multiple copies because you cannot guarantee that you're going to get them back. Okay, so make sure your family members know where your MG information is. Okay, anything for the paramedics, keep it on the fridge. Most paramedics know to look on the refrigerator for medication information. Okay, and medical information. Okay, so it can be a friend, it can be a family member. If you're not married, find a bestie. Find somebody that you can turn to, okay? Because you cannot be sure that when you're in crisis, you're going to be able to effectively communicate with that healthcare team, okay? And if you have a really good second, they can help prevent that misdiagnosis of anxiety. So you know what? She's not anxious. You need to come up and see her, okay? This is legit. This is real. Do those tests that are on here, okay? And finally, a medical alert bracelet should be worn. I've got mine right here, okay? I know that if I go to the emergency room, the average ER doctor will not know what myasthenia gravis is, okay, or what to do. However, anesthesiologists are very, very aware of myasthenia gravis. The reason I have it on is that if I need emergency surgery, hopefully they're going to tell the anesthesiologist, my apologies, so that they can take those proper precautions so that I can wake up afterwards. Okay, so that is the main reason that I have one on. Everybody should. Okay, they got cool ones out. You can really make them work for you. Okay, ER and EMT staff are trained to look for these. They will look for necklaces, but they are trained specifically to look for bracelets. Okay, you want to make it pretty, but if it looks too much like jewelry, they're going to think it is jewelry, and they're not going to realize it for the Med Alert bracelet that it is.
So with that great introduction about, the symptoms and how to prepare if you're in the unfortunate situation of having a severe exacerbation or crisis, we'll now move towards, what you may experience in the hospital setting. So this will be from the perspective of the physician, and I'll hit also on some of the things that Sally mentioned already and expand on some things and really emphasize a couple points that she made because I think that they're really important. Okay, and so the basic overview is we'll talk what crisis is from the neuromuscular specialist perspective, particularly coming from an academic neuromuscular specialist, and then we'll of course talk about how it will be managed. So before we get there, I just want to show this particular figure. Obviously, myasthenia can be a very serious illness and used to have a very high mortality rate. And so this is looking at myasthenia over the past 100 years, so in the 20th century, and looking at the mortality rate. So you can look up here, the mortality rate for patients with myasthenia used to be extremely high. And the point of this figure is to say that the majority of the advances of why the mortality rate has gone down has been in advances in managing myasthenic crisis. And so the important things here, we're just going to pay attention to the open circles here, are these advances in managing airways and the complications of upper airway compromise. So here we have tracheostomy and endotracheal intubation, which we'll talk about a little bit more, ventilation, and then here are antibiotics, right? So when patients have difficulty managing secretions and have weak airways, upper airways, sometimes secretions from the mouth can end up in the lungs, and that's called aspiration pneumonia. And so that used to kill a lot of patients, but now we have a lot more treatments available to manage those particular types of infections. And you can see how dramatically the mortality rate dropped with those two advances in medical care. There have been further advances along the way, including modern ventilators, which began in about the 1960s. And you can see how there was a steep drop in mortality rate after that advance. And then more recently, you can see the effect of plasma exchange. And then, of course, later on, IVIG. And so now the mortality rate, even for crisis, is down at about 2% in the United States. So the main point is that we've gotten a lot better at managing and treating crisis over the past 100 years or so. So now we'll talk about, from the academic neuromuscular specialist point of view, how we think about MG crisis. And so one of the important things for us and our center, and also, Dr. Howard's in the back from UNC, is are these recommendations that came out in the Journal of Neurology in 2000. And in this paper, it gives definitions for a lot of the terminology that's used. And as Sally mentioned, the terminology can be used differently depending on who you're talking to. So what is crisis to some groups of patients or even some neurologists is maybe different than the academic neuromuscular specialist that's aware of these guidelines. So we'll just go through this briefly. You don't need to read all this here, but it's just to show you that there are several different classifications that increase in severity. And myasthenic crisis would be down here at the bottom, and that would be someone that's class 5. And we'll go through the definition of that on the next slide. So as Sally mentioned, how do we get to crisis? She mentioned infections, pregnancy or postpartum period, medication noncompliance. So patients, abruptly stop their medication. That's been controlling their disease. Rapidly tapering medication. So particularly prednisone. If it's tapered too rapidly, patients can get worse. And also, as she mentioned, so illnesses, so serious illnesses or significant surgeries can often cause worsening. I have on a separate line here that medications can also be the culprit. And this is by far the most common thing that we see. And so on the next slide, I'll show you a list of some of those medications, and we'll highlight a few of those that tend to be the most problematic. That's probably one of the most important things to get out of this talk are those medications that everyone needs to be aware of. So getting back to our definition of crisis, according to the definition that was established by the Medical Scientific Advisory Board of the MGFA, it is defined by intubation. So it's patients that need a tube down their throat to keep their airway open. Okay, so that is crisis. And about 20% of patients will develop crisis, and it's usually early on in the course of the disease. And for most patients, if they're treated and managed appropriately, you usually don't experience crisis unless, some of these other things occur, particularly given medications. So here's a brief list of things to avoid. There's a more in-depth list on the MGFA website, and there's also a longer article that talks about these in more detail. But for all of our patients in our clinic need to be aware of these. And actually on the card for our clinic, for the MG clinic, on the back, we have these all listed out. And we also have handouts that we can give people, and there's a handout on the MGFA website that lists these medications. So you should have a copy of this list, and your other doctors that treat you should have that list as well. Particularly primary care doctors who may be treating, if you have a urinary tract infection or a sinus infection, they need to be aware of this list of medications so that they can choose appropriately to hopefully avoid complications related to a medication that's prescribed. If at any point you have a question or your doctor has a question, they should reach out to your treating neurologist that's treating your myasthenia to ask questions to make sure that what's being done is appropriate. I've bolded and underlined 3 drugs here. These are probably the 3 most common ones where people end up in big trouble. So azithromycin is commonly prescribed as a Z-Pak, which is a 3-day treatment. And Cipro and levofloxacin are widely prescribed drugs. These are all known within the quinolone class to exacerbate neuromuscular junction diseases. And we've seen patients who are doing extremely well, have very little evidence of myasthenia, get one of these drugs and within 3 days be in crisis on a ventilator. And realistically, that should never happen if people are paying attention. Okay, so now we'll expand a little bit on some of the respiratory care of patients, once they get into the hospital. So whenever possible, we want to try to use non-invasive ventilation, and that's the BiPAP that Sally mentioned. I'll show you another picture of that on the next slide. And we want to treat patients with the least invasive option whenever possible. So we never want to be in a situation where we have to put a tube down someone's throat to help them breathe, but sometimes that's unavoidable. So if we can get away with it with something less invasive, that's what we'll want to do. While patients are in the hospital at scheduled intervals, they'll have a series of breathing tests that are done. There are several different ways of doing these. The two that we use most commonly is one's called negative inspiratory force, and the second is called forced vital capacity. So for NIFs, or negative inspiratory force, you have a little apparatus with a tube on the end that you seal around your lips, and then you breathe in as hard as you can, hard and fast as you can, and it spits out a number. And so we track that number over time. Similar to the forced vital capacity, except we have you take a deep, deep breath and then force the air out as fast and hard as you can. And so we'll measure these numbers during the hospital course so that we can follow. Hopefully we're seeing things trend up so that things are getting better. But if we see the trend getting worse, then that's obviously a sign that we may need to change the management plan. We'll also evaluate secretions. So some patients have particularly when there's a lot of weakness around in the upper throat area and in the mouth facial muscles, they can have difficulty managing the secretions that are naturally there in their mouth and require suctioning. So we pay attention to that. And it's important to note that in some cases, we may stop acetylcholine esterase medications like mestinon or pyridostigmine. And so it's not that we're withholding treatment from patients, but for some patients and for some doses of these medications, secretions can actually get harder to manage. So we may just stop them or reduce their doses to hopefully make management of secretions better to prevent the aspiration pneumonia from the secretions going down into the lungs. We'll also monitor your oxygen, as well as sometimes, depending on the setting, your cardiac rhythms, things like that. So if necessary, we'll advance to intubation, and that's usually with a breathing machine, mechanical ventilation. If we get to that step, then usually that results in someone being on the ventilator for quite a while, so at least a week in most cases. And that's usually combined with doing some other aspects of management that we'll talk about in a couple minutes. If patients require ventilation for more than 2 weeks, we will consider doing something called a tracheostomy. So instead of having the tube down your throat, which is uncomfortable for patients and can lead to other complications, they'll put the tube down lower in the neck, and so that allows patients to hopefully talk, number one, but also avoid some complications from having the tube in for prolonged periods. We mentioned about suctioning, and then there are lots of other types of therapies that are used to kind of manage the respiratory aspects of crisis. So here are a couple more pictures. So here's the BiPAP, and as Sally mentioned, what this does is it basically puts a lot of pressure on the airways to hopefully open them up and kind of splint them open so that you can so that the patients can breathe. And so it's you can think of it sort of like a CPAP machine that people may wear for obstructive sleep apnea. And so here's an example of intubation. So this where the tube goes down into the trachea, so the upper airway, and then it's connected to a ventilator that manages the breathing parameters. And so some patients will require sedation while on that because it can be uncomfortable. So during a hospital stay for myasthenic crisis, the mainstay of managing the crisis and trying to get patients better as quickly as possible rely on these two treatments, so intravenous immunoglobulins and plasma exchange. So I'm just curious, so how many people have had IVIG in the audience? Okay, so a lot. Okay, and how about plasma exchange? Okay, so also quite a few. Okay, so it looks like a lot of the audience is already familiar with a lot of these treatments. And I mentioned IVIG yesterday, but we'll just go through these a little bit more. So therapeutic plasma exchange is also sometimes called plasmapheresis or PLEX. You'll sometimes hear it referred to. And then intravenous immunoglobulins. And I mentioned yesterday what that is. That's where they thousands of donors donate their plasma, and then they take the immune proteins, purify them, and package them together, and then that's infused into the patient. I'll talk about how plasma exchange works in a couple slides. So the choice of which therapy is used depends on several factors. So some of it relates to the patients themselves. So what other health issues the patients may have may dictate, the choice of using one versus the other. There are also physician preferences. Some people have more experience with one of these therapies versus the other and feel more comfortable using one. And there are also practical factors such as availability. Plasma exchange is relatively resource intensive, and some healthcare facilities may not have that available to them. Overall, the response of both of these is considered approximately equivalent, but there are a couple of things to note about that. Is that for MuSK, plasma exchange is preferred. So about 60% of patients with MuSK MG will respond to IVIG, whereas almost all of them will respond to plasma exchange. So for those patients, we prefer plasma exchange. And so plasma exchange, the response may occur a little bit earlier than you see in IVIG. And if you look at big series of hospitalized patients, more severe patients, patients more likely in crisis are more likely to get plasma exchange. And it's not entirely clear why that's the case, but I think the perception is from a lot of people that use plasma exchange and IVIG is that plasma exchange may start to have an effect a little bit earlier. So I mentioned IVIG is administered intravenously through a vein in the arm over a few hours. There's a total dose that's usually divided up over 2 to 5 days. And that division of how it's divided depends on patient factors, including whether or not you've had the medicine before. And as I mentioned, for both of these, the response you usually see clearly within 2 weeks. And IVIG is generally very well tolerated. The most common thing that we see is headache. That tends to be self-limited. So plasma exchange, on the other hand, is provided as a course of treatments, usually on an every other day schedule. Most patients will get 4 to 6 exchanges. So it's usually over a week, week to 10 days, that you'll get a course of plasma exchange. Each session takes 2 hours or so, 2 to 3 hours. That can vary somewhat depending on how they're getting access to the blood system, which we'll talk about in a minute. and the response is, again, within several days to 2 weeks. So most patients can receive plasma exchange through an IV, but that's not the way that it's typically provided in the United States. So in Canada and in Europe, almost all plasma exchange treatments are given through peripheral IVs. In the United States, most places only do it through central lines. So at our institution, we also do it through peripheral IVs, and also I know that UNC Chapel Hill also does it, performs the procedure through peripheral IVs. And you may read that plasma exchange can have a higher complication rate than IVIG does, but based on our research and our experience at our center, most of the complications are not related to the actual procedure itself, the plasma exchange, but it's more related to whether or not patients need to have lines in, the central lines, which are these big catheters that are either put into the neck or into the vein under the collarbone. So if possible, we always try to recommend that patients have plasma exchange through peripheral IVs. In some cases it's not possible, but we always try that first. So how does plasma exchange work? So if we take someone's blood and we spin it really fast, we can separate the different components of the blood into the blood cells themselves. They have the highest density, and so they sink to the bottom. And then you have the white blood cells, the immune cells, and then most of the blood is actually composed of the plasma. And within the plasma, we have a lot of water, and we have some other stuff. So we have sodium and potassium, calcium, lipids or fats, some hormones, and then we also have clotting factors and then immunoglobulins. And what we're really interested in are the immunoglobulins. So this is where, for the acetylcholine receptor antibody patients, this is what we're trying to remove, the immunoglobulins, the AChR antibodies. And so what we do with plasma exchange, it's kind of like filtering if you think about dialysis. So the blood is removed and it's spun really fast, and then it's separated just like this, and the plasma portion is taken out. And then there's a replacement fluid that gets reinfused back into the patient with their blood cells, the red blood cells and the white blood cells. So we're just removing, hopefully, the plasma and the bad antibodies that we want to get rid of. So, and this isn't a great picture, but here's one of the machines here with the plasma. So there's usually a bag, and the plasma gets collected in a bag. So this is being performed through a peripheral IV. Here's an example of one of the catheters I was telling you about, the large catheters that are sometimes tunneled under the skin. And so just an example, so it looks like a lot of patients have had this procedure, but if you're not familiar with it, I just wanted to give you an example of how patients do with this therapy. So this is an example with plasma exchange, but the response would be similar for someone getting IVIG. So this was a new patient who had never been treated before. And so the patient came in, and on the y-axis here, we have the myasthenia gravis composite score and manual muscle test. And so these are two quantitative scores that involve physician assessment of patient strength, as well as for the MG composite, some patient-rated assessment of their breathing and swallowing and things like that. So you could see, so the higher the number, the worse they're doing. Okay, so you can see on the MMT, they're 18 and 20 for each of those. And then on the x-axis is the time course, so over the number of days. And the arrows indicate when plasma exchange was provided. And so in this case, there were 5 treatments. And you can see by the 3rd treatment, we started to have this effect here where both scores started to come down. And by 1 week, they were down to a 4, which is that we love that. That's a very good response for this particular patient. Since this was a new onset patient who had never been treated before, If we just do plasma exchange or IVIG, eventually they'll relapse, okay, where they'll probably get worse. So we need to do something else. So in this case, the patient was also started on prednisone. We've also found that if you start patients on plasma exchange first or give them IVIG before starting high-dose steroids, the likelihood of worsening, which Sally mentioned with steroids, is reduced. So we like to manage it in that particular fashion. Okay, so in conclusion, the most important thing, which gets back to Sally's talk, is that we want to avoid going to crisis. We don't want to go there. So with the information that Sally's provided about the warning signs and how to prepare yourself, and your treatment team, your doctors, your husbands and wives and sons and daughters, to know about what to do and how to communicate with your neurologist and your treating physician, we always want to try to avoid getting to crisis. And in particular, we want to be aware of those MG alert medications. And if you notice any changes in your status, contact your neurologist so that they can either see you or make an intervention to hopefully, turn the tide and hopefully avoid getting to crisis. But if it does happen, as I've shown, is that most patients will do very well when they're managed appropriately with the available therapies. So that's it. Thank you.